مساء الخير. This session will be presented by Professor Richard Glassock, titled Therapy of Immunoglobulin A Nephropathy in 2022. Professor Glassock is a very known figure. Professor Glassock is an emeritus professor of medicine at the David Geffen School of Medicine in UCLA. He is an internationally recognized authority in clinical nephrology with a special interest in glomerular disease and particularly IgA nephropathy. He is a past president of the American Society of Nephrology and the National Kidney Foundation. He has published over 750 scientific papers, books, book chapters, and monographs. All the nephrologists, of course, are aware of his textbook, the Reference Nephrology with Dr. Glassock. Okay, we can start. Professor Glassock is. Do you hear me, Professor Glassock?
Good evening to you all. I'm very pleased to be back to the ESNT, and the topic for discussion today is quite a dynamic one. I put in the title that the status as of February 2022 or IgA therapeutics will be covered. I gave a similar talk about 3 months ago, and it's already obsolete. I suspect that this talk will become obsolete too in a relatively short period of time. Well, IgA nephropathy should be familiar to all of you, but I will remind you of a few key facts. First of all, it requires a biopsy for diagnosis. We can't yet diagnose by non-invasive means. There are three basic patterns of injury: endocapillary or mesangial proliferative GN without crescents, about 2/3, superimposed crescents in about 1/3, and very uncommonly minimal change disease. We have a pretty good idea of the pathogenesis of the disease involving several hits and the formation of immune complexes with an autoantibody directed to an aberrantly glycosylated IgA1. Most, but not all, patients with IgA nephropathy will progress, and we do know several factors now that contribute to progression that are listed here. I don't have the time to go into each and every one of these in detail, but they each make a contribution to the risk of progression, and they need to be taken into consideration in making decisions about treatment. So I would urge you to keep these topics in mind when you see a patient with IgA nephropathy, because they are likely to contribute to how you decide to manage the patient. Proteinuria is one of the key prognostic factors, as shown here from an old study from Canada, showing the extent of proteinuria as a time average basis and the outcome at 15 years after diagnosis. Very clearly, there is a graded influence of time average proteinuria on outcome, and this factors in to decisions about treatment. The biopsy, too, contributes largely through the assessment of the Oxford classification, the so-called MEST C-score, which involves mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, tubular atrophy, and crescents, and each of these make a contribution to varying extents on the long-term outcome. I'll be mentioning this later on in the context of how the MES score figures into determinations of treatment. Now, many of these factors that I've mentioned about prognosis have been incorporated into a new tool for estimating prognosis quantitatively. The International IgA and Risk Prediction Tool, which is now widely used, includes a number of variables, very importantly, proteinuria at biopsy and the Oxford MES score at biopsy. For interesting reasons, the scoring does not include either hematuria or crescents. That is just the way the tool was evolved, and patients can be categorized into 4 risk groups: low, intermediate, higher, and highest, based on their 5-year projected risk of end-stage kidney disease or a 40% decline in GFR from discovery. Obviously, it is the patients at higher or highest risk that become candidates for treatment. Now, there are a few caveats about the use of the MES score and the risk prediction tool in treatment decisions. They clearly are very important for the stratification of subjects enrolled in clinical trials. However, none of the published trials, except for 2, have used the Oxford MES C-score or the International Prognostic Score for stratification and enrollment. So we have very little data on the impact of either the MES C-score or the IgM risk prediction tool on outcomes following treatment. So the utility of these parameters for making treatment decisions have not yet been validated, and we need prospective studies so that we can use these tools for making decisions about use of specific regimens. Well, with that introduction, let me now enter into the ever-changing scene in treatment of primary IgAN. I will not be covering the treatment of IgA vasculitis or minimal change disease with IgA nephropathy. As of 2022, there are some basic standard of care measures that should be applied to all patients. First of all, their prognosis should be assessed using the International Risk Prediction Tool, which is available online at www.qxmd, and one should use a recent kidney biopsy graded according to the Oxford MES C scoring. This is for prognostic purposes only. One should control the blood pressure quite strictly. The values below 120 to 130 millimeters of systolic, with RAS inhibition preferred, either an ACE inhibitor or an ARB, but probably not both. If the proteinuria persists greater than 0.75 to 1 gram a day, you should give RAS inhibition even if the blood pressure is at goal levels, and add sodium restriction or a thiazide diuretic as needed. Patients at the high risk of progression are considered candidates for more aggressive therapy if RAS inhibition alone does not cause a reduction in proteinuria to goal after 3 to 6 months. So let's examine the use of drugs beyond angiotensin converting enzyme inhibitors or ARBs in the treatment of primary IgAN, and let's start with steroids. Well, there have been a large number of randomized controlled trials between 1986 and about 2018. 29 have been conducted, and a very nice systematic review and meta-analysis was published in 2019 showing that in these trials, steroids reduce the hazard rate of end-stage kidney disease by about 60 to 70%, with a substantial reduction in proteinuria. Uh, thus, these agents have become standard of care. Now, the value of adding steroids to RAS inhibition varies according to the magnitude of the baseline proteinuria. If the baseline proteinuria is less than a gram a day, as shown in the Valiga observational study, there's no benefit of adding steroids. If the proteinuria is between 1 and 3 grams per day, there's no benefit for the first 5 years. But after that, there appears to be a greater drop-off in patients treated with RAS inhibition alone, and those who have greater than 3 grams of proteinuria. The benefits of adding steroids are evident very early in the course of disease. 2 trials were conducted in the last several years that require careful attention. The STOP IgN trial, conducted solely in Europeans, and the testing high-dose trial, conducted almost exclusively in Chinese. 162 patients were in the STOP IgN. The testing high dose was much larger. There were big differences in the amount of proteinuria at baseline, averaging 1.6 grams per day in the STOP IgN, 2.4 grams a day in the testing trial. Kidney function was was significantly reduced in the high-dose steroid therapy. The regimens differed. The follow-up differed largely because the high-dose testing trial was prematurely stopped for safety. The MES-C scores were not known at the time of the study in either case. The results of the STOP IgN trial were interesting in that at the conclusion of the study at about 3 years, there was a greater extent of full clinical remission in the supportive care plus immunosuppression group. However, during this follow-up period, there was no difference in the rate of decline of GFR greater than 15 milliliters per minute in the 2 groups, largely because the rate of decline of GFR was very slow in both groups, perhaps as a result of the fact that the patients admitted to this trial had very mild disease, at least as determined by proteinuria. 10 years later, a follow-up of the original patients allocated again showed no difference in eGFR loss or end-stage renal failure. Therefore, STOP AGN was a negative study. No benefit of steroids, but of course this might have been due to the fact that they enrolled relatively low-risk patients. Now, there was a post-hoc analysis of the STOP IgN trial to examine the role of MES-C scores, and there was no consistent effect of MEST score on outcomes in the supportive or immunosuppressive therapy group, but end-stage kidney disease did increase in frequency in those with T1 and T2 lesions at baseline. And there were non-significant trends towards better outcomes in the C1 and C2 crescentic group compared to the C0 crescentic group with immunosuppressive therapy. But this is a hypothesis-generating trial, very small numbers, and a prospective trial is needed. There has been an independent examination of the predictive value of Oxford MES-C, published very recently, was again a retrospective study. All of the patients were treated with immunosuppression, and the outcomes relative to the Oxford MES-C scores were examined. Only M1 and T2 scores were associated with poor outcomes of immunosuppressive therapy, but the other lesions didn't correlate with better outcomes. Well, because of the premature abandonment of the high-dose testing 1 trial due to high risk of even fatal infectious events. A second steroid trial was designed in which a low dose, I'm sorry, the results of the high dose trial, I got a little ahead of myself here. The high dose trial did show a benefit in terms of proteinuria and a benefit in terms of GFR. GFR was better in the steroid treated group and proteinuria fell. So it was a positive study, but it couldn't be interpreted because of the premature closure due to the adverse events. So a reduced dose trial was designed, very large numbers, extended the recruitment beyond China to other countries. It was placebo-controlled, double-blinded, and masked, and for the first time, the treatment groups were stratified by the E-score in Oxford MEST. There was a 5-year follow-up, and the dosage was half that used in the high-dose trial, and pneumocystis pneumonia prophylaxis was required. The results were published during the Renal Week in 2021. They've not yet been published, but I'm certain they will be soon as they have been submitted for publication. Those of you who attended the ASN meeting virtually know that the testing moderate dose trial was clearly a positive trial with striking benefits in terms of the hazard ratio for primary outcomes of decline in GFR or end-stage kidney disease in both the full dose, which had been shown previously, as well as the reduced dose. In fact, the reduced dose had an even more powerful effect on outcomes, at least for up to 3 years after enrollment. So the moderate dose testing 2 trial confirmed the findings in testing 1 at half of the dose of steroids without side effects. And in fact, when you examine the benefits and harms of steroids in these 2 pivotal trials, high-dose steroids benefit is offset by harm in about equivalent degrees. But with the reduced dose, the benefit greatly overrides the additional adverse events. So it is not only beneficial, but not harmful. So the conclusions from the testing trials are that oral systemically administered steroids in the form of methylprednisolone in moderate dosage and gradually reducing dosage over 6 to 8 months are both effective and safe in delaying progression in patients with IgA nephropathy with persisting proteinuria, somewhere between 1.2 and 4 grams per day at baseline. And this occurred in both Chinese and non-Chinese subjects, and higher doses are no more effective and probably are unsafe. In data I didn't have time to show, the Oxford MEST E-score did not differentiate the effectiveness of therapy, and C-scores were not examined. But it is important to know that there were no European or American subjects enrolled in either of the testing trials. So one might raise the question as to whether these trials can be universally applied to all of the global population. There has been a small randomized control trial of intravenous methylprednisolone and alternate day steroids, comparing this with standard high dose daily oral methylprednisolone, a treatment similar to that used in the high dose testing trial. And I'll summarize the outcome. There's no difference in outcome when you use pulsed IV methylprednisolone for treatment of IgA nephropathy. So at the moment, there doesn't seem to be any clear role for this therapeutic approach, and oral moderate dose steroid seems to be effective and safe. Now let's turn to some additional steroid trials, but using a form of steroids that is different than the oral systemic forms. That is Nefecon, which has been studied in the Nefegan and Nefegard trials. The original Nefegan trial was reported a few years ago in Lancet. It was a double-blind placebo-controlled trial of a specialized formulation of budesonide, a very potent glucocorticoids. Theoretically, this special formulation releases active steroids in the ileum, where it acts locally on Peyer's patches to reduce the production of the aberrant IgA and IgA antibody. The steroid is then partially absorbed, undergoes first-pass hepatic metabolism, and greatly decreases systemic steroid effects. The phase 2 trial had 150 subjects treated for 9 months and then followed 12 months. And the main primary endpoint was a reduction in proteinuria. These patients had relatively mild disease, fairly similar to that seen in the STOP IgAN trial, and the MES C-score was unknown. The outcome in this trial showed a reduction in proteinuria compared to placebo, and a stabilization of the GFR when followed up to 12 months. The study was not powered to study end-stage kidney disease, obviously, with such a short follow-up. There were systemic steroid-related adverse events occurring in about 2 to 3 times that seen in the steroid, in the placebo group. So it's likely that some of the administered budesonide did appear in the systemic circulation. So it's not 100% preventative of steroid-related side effects. But it does lower proteinuria and stabilize eGFR, and the adverse events are not overwhelmingly high, even though they are present. A phase 3 trial has been completed, and in a press release, the Callidas company who sponsored the trial, the phase 3 confirmed phase 2, and on the basis of this data, Nefecon has been approved by the U.S. Food and Drug Administration as of December 15, 2021, the first drug ever approved by the FDA specifically for the treatment of IgA nephropathy. However, the approval for use of this drug in IgA nephropathy is limited to the reduction of proteinuria. It does not extend to a reduction of the rate of CKD progression or the prevention of kidney failure, and studies in progress will be required to answer this question. The approval is also silent on the mechanism of action, but one anticipates commercial rollout of this drug, at least in the United States. I don't know where it will do globally, is expected in the first quarter of 2022. Now, I'll mention very briefly the non-steroidal treatment of IgA nephropathy because it's much less well established. Mycophenolate mofetil is apparently effective, but only in Asians. It's not effective in non-Asians, as studied in USA and Europe. Azathioprine is not effective and possibly harmful. Leflunomide may be effective in Asians, but there's no studies. in non-Asians. Calcineurin inhibitors like tacrolimus or cyclosporin is very uncertain. They certainly can be antiproteinuric over the short term, but nephrotoxicity of great concern for long-term use. There are no, repeat, no long-term randomized control trials. Cyclophosphamide showed no benefits at all in stop IgA. However, it might be beneficial in crescentic disease, especially when rapidly progressive glomerulonephritis is present, but randomized controlled trials are needed. Rituximab appears to be ineffective. ACTH might be effective, but there's no randomized controlled trials. Fish oils are safe, but probably not effective. Hydroxychloroquine is effective. It will reduce UPCR, only studied in Asians, in one small randomized controlled trials, and SGLT2 inhibitors I'll be discussing in a moment. Tonsillectomy, very uncertain. 2 randomized controlled trials have shown only weak effects exclusively in Asians. It might be more effective with crescentic disease. It's quite commonly used with pulse steroids in Japan, but nowhere else in the world. Plasma exchange in patients with rapidly progressive glomerulonephritis has been used in 2 uncontrolled trials, both from Asia, suggesting efficacy in C1 and C2, but there are no randomized controlled trials. Now, I'd like to spend a few minutes in SGLT2 and IgA nephropathy because this is new data. From the DAPA-CKD trial, which consisted of 4,304 patients with CKD treated with dapagliflozin 10 milligrams a day in a double-blind fashion, and there were pre-specified primary outcomes in a variety of subgroups using sustained decline of GFR by at least 50% from baseline and kidney failure or death from kidney disease. Most of the patients in the DAPA-CKD trial had diabetic nephropathy as shown here, but 6% had IgA nephropathy. In the IgA nephropathy group, they were both Asians and Caucasians. They tend to be old, tended to have rather poorly controlled blood pressure, elevated serum creatinine, and modest proteinuria. There were no MAS-C data in any of the enrolled subjects, and the IgA prognostic tool was not calculated for either the placebo or the active drug treatment. But the effect of dapagliflozin on patients with IgA nephropathy, more than 270 patients randomized, was extremely impressive. 15% of placebo-treated patients developed the cumulative endpoint by 32 months, whereas only 4.4% of patients treated with dapagliflozin reached the same endpoint. Very impressive results. However, no RCTs of SGLT inhibitors exclusively in patients with RAS inhibitor-resistant cases of IgA nephropathy have yet been conducted. So this is based on a pre-specified endpoint in a group of patients in which IgA nephropathy was represented in about 6%. However, if these data are confirmed by the EMPA kidney trial, which is now in progress and will likely be available in the latter half of 2022 or early 2023, in my opinion, it will be very difficult to conduct clinical trials in IgA nephropathy without SGLT2 inhibitors as a standard of care. In fact, in the USA, dapagliflozin has been approved for the treatment of proteinuric CKD, including patients with IgA nephropathy. So in summary, as of February 2022, there is general agreement that RAS inhibition alone, or perhaps in very exceptional cases in combination, is indicated in all patients with biopsy-proven IgA nephropathy with certain goals of proteinuria and blood pressure. When proteinuria persists despite optimal supportive therapy, adjunct steroid therapy using oral moderate dose prednisone or Nefecon is indicated, but the optimum formulation, oral prednisone or specially formulated budesonide, and the duration of therapy for a favorable efficacy and safety ratio is uncertain, as there have been no direct comparisons between Nefecon and moderate dose systemic oral steroid therapy. We don't know yet what the lower limit of GFR acceptable for treatment is present, but in the absence of rapidly progressive GN, it's probably on the order of 20 to 30 mLs per day. Obviously, all trials going forward should utilize both the international prognostic indexes and the Oxford C-scores from a recent kidney biopsy and can use both proteinuria and change in GFR as endpoints. Unfortunately, we don't yet know the role of adjunctive therapy with combined immunosuppressive therapy when patients have crescentic disease. We need randomized controlled trials. You all know that a new CpG for IgA nephropathy was released by the KDIGO in October of 2021. And as I've just shown you, emerging information is likely to change these guidelines. But patients who wish to avoid exposure to steroids, who fail to respond to steroids, should be strongly encouraged to enroll in ongoing trials of novel agents or repurposed existing agents. In summary, IgA nephropathy is a progressive disorder in many but not all patients. The prognosis in individual patients can be reasonably estimated by a collection of a variety of pieces of evidence. RAS therapy is the cornerstone of management, and SGLT2 inhibitors may be added soon. Steroids are effective when given in moderate dose and safe, but the optimum formulation and duration of therapy are still unsettled, and we need a lot more data to answer the questions about the use of combined immunosuppression. Treatment must be highly individualized, and promising novel therapy, immune modulators, complement inhibition, hemodynamic modifiers are on the horizon as phase 2 and 3 trials are in progress. Thank you very much, and I look forward to being with you at the meeting in a few weeks to answer any questions you might have.
Thank you, Professor Glassock, for this very nice and most recently educating the recent treatment or recent trends in treatment of IgA nephropathy. Are you with us, Professor? Professor Glassock? معانا؟
Please ask questions if you'd like, and I may repeat them if I don't understand them perfectly well. So go ahead.
Okay. Any questions?
I have a question, Professor Sabri.
Sorry.
Yes.
I'm Gamal Saad.
Hello, Professor. Hello, Professor Gamal.
Thank
Yes.
you very much, Professor Glassock, for your very elegant presentation, and we always learn from you. I would like to ask you about benefit of the mineralocorticoid antagonist with interest blockade?
That is an excellent question and a very contemporary one. As you know, several large randomized controlled trials have shown a distinct benefit of non-steroidal mineralocorticoid antagonists on the progression of diabetic nephropathy. Studies are in progress to examine whether that benefit extends also to patients with non-diabetic chronic kidney disease, including IgA nephropathy. These studies are similar to those which were performed with SGLT2 inhibitors. The question that is often asked is whether RAS inhibition combined with mineralocorticoid receptor antagonists will produce such severe hyperkalemia that it will limit the ability to use these drugs on a chronic basis. The evidence currently is that that probably is not the case. With non-steroidal mineralocorticoid antagonists, even combined with RAS inhibition, the occurrence of severe hyperkalemia is not common. And perhaps when you add SGLT2 inhibitors, hyperkalemia will even be less common. Also, if hyperkalemia does occur, it can be managed easily with the addition of a potassium binding resin. I think we'll have to wait until the phase 3 trials with non-steroidal mineralocorticoid antagonists are completed to make any firm statements about whether they are or are not indicated in IgA nephropathy. But the prospects for their benefit, I think, in this category of disease appear quite logical, and I am optimistic that ultimately they will be found to be useful.
Are
Ahmed,
there any updates? Are there updates about the stage of kidney disease of which you have used Nephropathy? Can we still use it up to stage 5 or early dialysis?
Well, the product information brochures say that you should not use SGLT2 inhibitors when the eGFR falls below about 30 milliliters per minute per 1.73 meters squared, possibly because of the risks of inducing AKI. However, in small studies, mainly observational, the risk of AKI in patients with more advanced kidney disease do not appear to be limited. I think we need more data to make an objective, evidence-based answer to that question. I don't think SGLT2 inhibitors would have much benefit in patients with end-stage kidney disease. That may not be true with mineralocorticoid receptor antagonists and RAS inhibition, but I think we just simply are in a period right now where we can't say for certain that the use of SGLT2 inhibitors in patients with more advanced kidney failure or kidney disease, including IgA nephropathy, have a favorable benefit-harm ratio.
Dr. Ahmed,
Yes, Ahmed Adam from Alexandria. Do you hear me, sir?
Yes, how are you?
Thank
I
you.
love you. I haven't seen you this year.
All right, yeah, thank you very much. I love you too. Actually, my question is already raised by Professor Sadi, but I will rephrase the question. Which level you cannot start SGL2 inhibitor in CKD and IgA nephropathy, and which level you must stop if your patient is still on it? Which level you must stop the SGL2 inhibitor in your patient? Especially that the cardiology love this. So from the cardiology point of view, they want us to continue even if it is less than whatever. So
Well, I can give you my personal opinion. In a patient with congestive heart failure, class 2 or 3 or possibly class 4, who has failed to respond to RAS inhibition, sacubitril, beta adrenergic antagonists, and mineralocorticoid antagonists, I think you can use SGLT2 inhibitors probably at any stage of CKD. Now, of course, that hasn't been firmly established by a prospective randomized trial in which patients were selected for having GFRs less than 30. But I think there is every reason to believe that these drugs may have beneficial effects on congestive heart failure, even in more advanced stages of GFR. I wish I could say that this has been firmly established by evidence, but it hasn't.
Thank you very much, Professor. Thanks a lot for that. And we are obliged. Okay. No, please, because they are. Thank you very much. Thank you very much.
Hey, you're very welcome, and I wish you the very best in your meeting, and I'm sorry I'm not with you this year, maybe in subsequent years.